Okay, chapter 33, the final chapter for the week. Chapter 33 covers environmental emergencies. Environmental emergencies are just as they sound, things that are caused by your environment. I actually kind of like this chapter. There's a couple of parts of the chapter, particularly when we're talking about wildlife, that I enjoy. Of course, when we're talking about patients with heat and cold emergencies, they're certainly prevalent, and a lot of potential for us to see those in our neck of the woods here. So. Your objectives. Objectives are on pages 804 and 805. Just a few of those for this chapter. Multimedia slides or videos, emergency near drowning video, and then the effects of venomous snake bite video. Our core concepts to look at: effects on the body of generalized hypothermia, and the assessment and care of hypothermia, the effects of the body for local cold injury and the assessment and care of those, personal effects on the body of the patient exposure to heat, assessment and care of heat exposure patients, signs, symptoms, and treatment for drownings and other water-related injuries, signs, symptoms, and treatment for bites and stings. So, cold emergencies. The body loses heat in really five different ways: conduction, convection, radiation, evaporation, and respiration. There's a fairly good picture that represents this on page 806 in your textbook. Shows you a few ways in which this happens. So if we're talking about radiation, this is body heat lost to the atmosphere or nearby objects without physically touching them. So in most cases, when we are kind of just, you can feel the heat coming off of something like a radiator in an old house. That's how radiation works. Convection. This is body heat that is lost to the surrounding air, which becomes warmer, rises, and is replaced with cooler air. So convection ovens use this some similar property where actually you are losing it to the air, and usually it has to do with air moving over you, and that air moving over you cools you. Respiration, obviously we have 98.6 degree air in us. When we exhale it out, we lose that. We take in a breath of room temperature or whatever our environmental temperature air is, and that the mean temperature of that slowly and slightly comes down. So evaporation, this is perspiration or wet skin. That water evaporates off there, causing the body to cool. And then via conduction, the body heat is lost to nearby objects that it's directly touching. So sitting on that cold concrete, this time of year when we're talking about football games, football playoffs and whatnot, sitting out in cold bleachers or wherever, and not having any padding between you and the bleacher, so there's no insulation. So generalized hypothermia. This is exposure to cold that reduces the body's core heat, and the body's unable to maintain a proper core temperature. It does occasionally lead to death, and then there are a number of predisposing factors for hypothermia. If you have somebody who's injured, somebody who has chronic illnesses, under the influence of drug and alcohol, geriatrics and pediatric patients, they're not as well suited as the strong, healthy adult to deal with the extreme cold temperatures. Now, when I say extreme cold temperatures, it doesn't have to be extreme cold. Even a person that's been in an environment that's 60 degrees, 70 degrees in some cases, could suffer from hypothermia. It just takes a long enough exposure and the body not creating any heat to bring that body temperature down. So movement obviously creates heat. It expends energy. So there's some obvious and some subtle exposures, such as Alcohol ingestion makes you so you're not quite as in tune to your environment. Underlying illness, you may always be cold, you may always be hot, and not realize that you're changing overdoses of poisoning. Much the same as that of alcohol ingestion. And then major trauma, when you're losing blood, you're losing ability to function appropriately. So assessment for hypothermia. Number one, look at the environment that they're in. Pay attention when you walk into somebody's house. Man, is it cold in here? And you've got your jacket on. And the person maybe is sitting around and they don't have a jacket on. So paying attention to the environment that the patient is in or is found in. Is the patient wet? Patients in wet clothing are at a much higher risk of getting cold. So you start looking for shivering. Shivering happens in early stages. Eventually the shivering goes away in the later stages of hypothermia because the body has used up all of its resources. They may start to have some numbness or tingling, stiff or rigid posture, drowsiness, rapid breathing or pulse initially. In very late hypothermia, their rapid their breathing and pulse will actually go way down. A loss of motor coordination. Unconsciousness in some cases, and cool abdominal skin temperature. When we check a patient's skin temperature, number one, we need to kind of acclimate to their environment for a moment before we try to make any assessment on, oh, you feel hot or you feel cold. Their environment is different than the environment that we've just come in, say in the ambulance with the heater on full blast, and we walk into a little bit cooler environment, and everybody may feel cool. But after we've had a few moments to acclimate to their environment, we can do a better job of testing that. And we usually will try to feel their abdomen to get a better accurate look at their core temperature. So rewarming. In most cases, we are not going to actively rewarm patients. We will do some passive rewarming from time to time, but applying external heat can get dangerous. Depends on the patient. Central rewarming we can do by applying heat packs or warm packs to their chest, their neck, their groin, their armpits. That helps move heat into the body. So passive rewarming, just removing wet clothing and covering the patient, goes a long ways. Turn the heat on in the ambulance. That's the steps we're going to take. We're not going to try to get this person too warm too quickly. Sometimes it actually has some fairly negative side effects when we do that. And active rewarming in patients with the next type of emergency we talk about, which is frostbite, can actually backfire on us on occasion. Okay, so the extreme hypothermia. Patients are unconscious. They have no discernible vital signs. Maybe we have to take a pulse for an entire minute, and we get with a lousy little 10 beats per minute. They're extremely cold to the touch. They don't appear to be breathing at all. If we do not feel a pulse or we don't have any accurate pulse, start CPR. You can use your AED if necessary. It may not be effective, but you can try it. And then if the patient does have a pulse, let's care for them as unresponsive patients. And we have a saying in EMS that you're not dead until you're warm and dead. So hypothermic patients, we will continue to work them for quite a while until we're sure that their body core temperatures return to a fairly normal state, and their body essentially has given up. There are stories of people, and there are accurate stories of people being under cold water for up to 45 minutes and coming up and having no permanent deficit. So it's possible. So localized cold injuries. These most commonly affect the ears, nose, face, hands, feet, so the little tissues. The blood flow is really limited because the blood vessels have constricted to try to keep the body heat in. Tissues are going to freeze and can form ice crystals. Remember, your body is mostly water. So if it gets down that cold, it will start to freeze. We can have earlier superficial localized injury, which is often called frost nip. You just simply need to remove them from the cold, dry them off, cover them up. They'll be fine. Later cold injuries such as frostbite, we need to cover it up, get any wet clothing off of it, remove anything that's constricting, and then it's usually a good idea to also immobilize it to prevent it from becoming traumatized in the process of moving them. So it's not a bad idea to cover it with good, warm, dry, sterile dressings. And then if you've got something like a moldable splint, SAM splint, it's a good idea to mobilize. So heat exposures. Heat is not needed for temperature maintenance and is not lost. It creates hyperthermia. So if we are not trying to raise our body temperature, but we don't have any way of getting rid of this excess body temperature because we're out running or working out or what have you, in an extremely hot, humid environment, we have the risk of developing hyperthermia. If we leave it unchecked, this leads to death. You can develop things such as heat cramps or heat exhaustion, which will typically have pale, moist, and normal to cool skin, or heat stroke, which is the emergency end of this, which is hot, dry, potentially moist, but in most cases heat stroke patients are hot and dry and very red skin in most cases. So heat exhaustion, probably most of us have actually suffered from this at one point or another. We start to get muscle cramps, weakness or exhaustion, rapid shallow breathing, our pulse may become weak, we may have been sweating and are completely soaked in sweat, all of our clothing is soaked in sweat. It is possible to lose consciousness because you're minorly dehydrated now, chemically, and your water balance is off. So it is possible for you to have some syncopal episodes. Heat exhaustion treatment in general, removing from a hot environment, administering oxygen, loosening or removing clothing, and positioning them supine in most cases, so basically blood easily flows back and forth to the brain. If your protocol allows it, you give them some small sips of water or a sports drink that has some electrolytes in it, because that's really what they're missing, is the electrolytes and the water both. Transport, in some cases we will try to cool them a bit. It's not radical, but taking some cool compresses or even a sheet and putting it in some cool water, placing that over the patient helps them kind of cool their core down a little bit. Heat stroke, on the other hand, you have rapid and shallow breathing, rapid full pulse, usually it's very bounding, generalized weakness, little to no perspiration, that's kind of a key assessment sign there. Altered mental status, dilated pupils, and seizures. All these can be a sign of heat stroke. Heat stroke is a very big emergency. We need to get them out of the hot environment. We need to remove their clothing. We need to get them cool and cool quick. So cool packs in the neck, the groin, the armpits, covering them with cool, wet sheets, or misting them with water, administering oxygen, and immediate transport. So we're going to talk water-related emergencies. There were types of accidents occurring on or near the water. Involve boat, water skiing, windsurfing, jet skiing, diving, scuba, etc. A lot of these also involve alcohol or children. The most common most common events that we deal with are drowning incidents. In often cases, a person struggles to keep afloat. When they submerge, they try to take a deep breath and may have water enter their airway. Involuntarily, they're swallowing water. They may actually have their airway spasm shut, so water can't get in it. But when it's spasmed shut, neither can air. And then if they're underwater, obviously there's no air for them to get to. Drowning is a term that formerly was used to represent a person who died from this, but drowning is actually now used for any incident in which a person suffers a submersion injury, whether or not they die. So you can have a fatal or a non-fatal drowning. So you get this reflex of the spasm. reflex spasm of the larynx seals off that airway. Usually become fairly unconscious quick. Some who die just die from a lack of air as opposed to water in their lungs. Occasionally, people will actually die. They suffocate with their dry drowning, but over time, then water seeps in, so it's difficult, depending on how long they're down. Most attempt to take a final breath or are unconscious, and then water will finally enter their lungs in some cases. So treatment, begin rescue breathing without delay. If you reach a non-breathing patient in the water, support the patient in a semi-supine position and provide ventilations. You can't do chest compressions on them in the water. There's nothing to press on. So you may encounter airway resistance simply because they're spasmed, so you may have to ventilate a little more forcefully. Do not delay transport. You should strongly consider that this may also have been a diving accident. So final immobilization in the unknown cases are appropriate. If you would have a patient that's a drowning that does go into cardiac arrest, make sure that you're careful to dry off the patient prior to applying a defibrillator and trying to defibrillate them. You being in the same puddle of standing water that they're in while you shock them could potentially be a very exhilarating experience for everyone involved. So with diving accidents, most of the time we're talking a head or neck injury. Occasionally they also have problems with hands, feet, ribs, spine. Emergency care is the same for any accident patient pulled out of the water. So we're going to treat them as a back injury. We're going to immobilize head, neck, and spine, treat the secondary injuries, treat the life threats, and transport. Scuba diving accidents. Occasionally you have the patient with a scuba incident. They may develop some blood gas embolisms or decompression sickness. And basically what happens here is gas bubbles change size. As the patient goes down, they get smaller. And as the patient comes up, they get larger. You may have gases that kind of migrate into different areas while the person is submerged. And then as that person starts to come back up, there's gas trapped in areas that it typically isn't supposed to be in. So if we have an arterial gas embolism, a lot of times this is as a result of the diver holding their breath. They maybe did not do their breathing exercises like they're supposed to, the smaller breaths, and make sure that they let their lungs deflate well as they're moving up and down through the water. Decompression sickness, they come up too quick. They didn't repressurize. They may have been down for a very long, prolonged dive. They came up very quickly, and some of those gas bubbles got retained. They were not expelled. Sometimes it can take up to 2 days for it to start to appear. Just as a quick point of reference, the Diver Alert Network is a service that has been formed to help emergency responders in cases of diver injuries, divers down, and so on and so forth. They can help you get appropriate information on treatment and assessment, care, and then transport to a hyperbaric chamber. And a hyperbaric chamber actually is putting this person in a big tube and changing the pressure, the environment they're around, basically simulating the same amount of pressure that they maybe went down while they were diving. And this allows the gas bubbles to change size again and then hopefully be expelled from the system appropriately. The hyperbaric chamber in the Omaha region is at the Med Center, Nebraska Medical Center, in the Clarkson Tower. So if you were to have to do water rescue, number one, you should be trained in water rescue if that's something you're going to be involved with. If you have no other resources and you have to do something, the general consensus is in this order. You reach, throw, row, and go. Try to have the patient reach for something, maybe throw them a rope, throw them a life ring. You row out there in a boat, and then finally swimming out there to them. They put them in this order because it's dangerous. If you go to the patient panics and you're going down. So ice rescue, again, something that requires specialty training. A lot of times it's, again, throwing flotation devices or ropes, pushing out a flat bottom boat or a ladder. What we have to do is we have to distribute weight over as big an area as possible to keep ourselves from going through. Treat your patient for hypothermia, and then always transport, of course. Suspected potentially also is a diving injury. You may also be dealing with a cardiac arrest. All right, bites and stings. All spiders are venomous, but they're not all dangerous to humans. There are actually only two significant families of dangerous spiders within the United States: the recluses and the widows. So there's a number of subspecies of recluse. I believe there's about 6 or 7, and there are actually 2 species of widows that are potentially dangerous. The black widow is what everybody's most familiar with, but there's also a species in the United States called the brown widow, and the brown widow also has some venomous properties, though it is not nearly as dangerous as the black widow is. So insect stings and bites are rarely dangerous unless the patient has allergies to them and they become anaphylactic. Insect stings and bites are annoying, they hurt, they make you feel like crap, but in most cases are not terribly dangerous unless, like I said, they are allergic to them. If you have a patient that has been stung and has retained the stinger, like most of the family of honeybees, the honeybee will leave its stinger behind. It's one of the final duties of the honeybee in its quest to protect is it pulls out most of its internal organs when it deposits its stinger into your skin. So it dies relatively soon after. But removing the stinger, there's a correct way to do that. Scrape the stinger away. Use like a knife blade or a credit card and scrape the stinger out. Do not reach down and squeeze it, because when they leave the venom sac behind, if you go down there and you squeeze the venom sac, you actually inject more venom. Snake bites. Snake bites require special care but are usually, again, not life-threatening. Death is not sudden unless there's an anaphylactic shock. Remain calm the patient. Be careful that you don't also become a victim of these snake bites. There's a couple of items regarding marine life poisoning, where we're talking about jellyfish stings and sea cucumbers and whatnot. Not something we routinely deal with in the U.S., but we should at least touch on it. That occasionally eating improperly prepared seafood could cause this, but most commonly it's going to be stings or punctures. Fresh water activates the toxins on the skin and it increases pain. So use salt water if possible to rinse the affected area. There is some truth to the matter in saying that there is some benefit in using urine on a jellyfish sting. There are also alternatives such as meat tenderizer and whatnot, but it is actually not untrue. So, chapter review. And remember that patients suffering from exposure to heat or cold must be removed from the harmful environment as quickly and safely as possible. In generalized cold injuries, involves cooling the entire body, called hypothermia. Treatment is based on their mental status. Patients who have hypothermia with altered mental status are considered severe. Local cold injuries such as frostbite need to be gently rewarmed if possible early, but if there's a possibility it could refreeze, we should not try to thaw any frostbites because it will come back worse and more painful. Late local cold injury involving freezing, transport rather than rewarming like I mentioned. Hyperthermia is a heat emergency where the body's heat loss does not exceed its cooling. All heat emergency patients should be removed from the heat and cooled. Altered mental status in the presence of hyperthermia usually indicates heat stroke and becomes a life-threatening emergency. Immediate resuscitation of water-related emergency patients may require quick and persistent interventions. Always assure that your own safety before water and ice rescues. For injections or ingestions of poison from insects, spiders, snakes, and marine life, you need to contact medical direction and follow your local protocol. One thing to kind of keep in mind when it comes to envenomation, yes, we have the insects in our general area. Very, very uncommon to run into a rattlesnake in our areas of Iowa and Nebraska. Not absolutely unheard of, but it's extremely, extremely rare. There are no coral snakes in our region. There are no water moccasins in this area. There are no copperheads in this area. There are definitely, like I mentioned, the spiders. There's definitely brown recluse spiders in our area, and it's not common to see black widows in this area. They tend to be a little bit more easterly and southerly. So, heat lost and gained through convection, conduction, evaporation, respiration, and radiation. And certain illnesses, medications, and underlying conditions make patients more susceptible to heat-cold injuries. We should actively rewarm and alert and responsive hypothermic patients, passively rewarm hypothermic patients with an altered mental status. So that active rewarming is getting them to participate in submerging parts in warm water and so on and so forth, whereas passively cranking up the heat, getting them out of their wet clothes, covering them up. We could do some warm packs if necessary. In a patient with signs of heat exhaustion and heat stroke, the EMT must assume that a heat stroke is present, or with the heat exhaustion with the altered mental status. Assume heat stroke. Active cooling is essential. It must happen. You must get cold packs in their pits and groin and neck, and then get them covered with some moistened, cool sheets. Provider should never attempt to do a water rescue or an ice rescue unless you're appropriately trained. We have a couple of specific problems that we see in scuba diving accidents, such as arterial gas emboli and decompression sickness. While not common to our area, we have the depth in the water that it could happen. It just doesn't seem to happen very often. When treating a scuba-related injury, contact medical control and determine the most appropriate destination, whether or not a hyperbaric chamber might be appropriate. Certain species of spiders, scorpions, and snakes can be poisonous to humans. So questions to consider: is the scene safe? How did this person's environment affect them, and how could it potentially affect me? How can I get the patient from the water safely or rescued from the ice? Does the patient have altered mental status? In the hyperthermia patient, is their skin cool or normal or hot? So you're with your family at a local lake. You observe a boat capsized near the middle of the lake. Screams can be heard from the scene. You are a marginal swimmer. Several civilians begin swimming out to the site. So apply the concepts you learned in scene size up to this scene. So you already have people headed out there. So you hopefully have some strong swimmers that are able to help rescue this person and not get themselves pulled underwater at the same time. You have the medical training, perhaps they do not, and so it's going to be up to you to kind of direct any patient care that goes on, and perhaps you are the one that's going to have to be making sure that the appropriate ambulances and first response services are called.